Just a reminder to you all that we'll get started in a few minutes, giving people time to make their way in. Great, we can probably go ahead and get started, and I can just let people in as they arrive. It's good to see everyone today. I know 8 a.m. is early. I'm excited for what we have in store for today. Normally, the first Echo Clinic of the month is substance use topic related, but we decided to shift for this month because Lionel was willing to come and talk to us about CBT kind of plus more for psychosis. And we wanted to give him that opportunity, and this was the date that worked. So we will have him speaking today. And then Claire is going to be doing our case presentation afterwards. So if we want to start with introductions, and then I will turn the floor over to Lionel. Piper, do you want to introduce yourself first?
Sure, I'm happy to do that. I'm Piper Meyer-Kalos, a clinical psychologist and also IRT clinician out at St. Louis Park, and one of the original developers of the Navigate model. Carissa, you've already introduced, so I will just go down my list here, and that would be Lindley.
Hi, I'm Lindley Broughton. I'm the case manager with the HOPE program at Hennepin Healthcare, and I will go to Melissa.
Which one? There's 3 of us now.
Melissa Delho.
I'm Melissa Delho, clinical social worker by background and program director for our Navigate program at the University of Minnesota out in St. Louis Park. And I am actually going to pass it to Max because I'm really digging your glasses right now. So
Thanks, Melissa. Good morning, everyone. My name is Max. I'm the family clinician at the Strengths program in Minneapolis. And I'm going to pass it off to Melissa Shudler.
Morning, I'm Melissa, and I'm the IRT clinician for the Strengths program. And let's go to the other Melissa, Melissa Rosewell.
Oh, she just popped back. Oh, she's back. Melissa Rosewell, you want to introduce yourself? If you can hear us, maybe not.
Let's do Bridget.
Hi everyone, I'm Bridget. I'm a clinical social worker and I administer DAs out of St. Louis Park. And I will pass it to Cecilia.
I'm Cecilia. I'm an IRT clinician at the Human Development Center in Duluth for our FEP program. And I will pass it to Jessica.
Hey, I'm Jessica. I use she, they pronouns. I'm a first year in the clinical science program, the clinical psych program really at the University of Minnesota here. And I've been working with Piper on some of the IRT for bipolar manuals. So thanks for having me. I'll pass to Nancy.
Morning, everybody. Nancy Howe. I'm the director of the children's program team for NAMI Minnesota and also the family peer for the HOPE program, Navigate Through St. Louis Park, and Strengths. And I will popcorn to Lionel.
Thanks, Nancy. Hi, I'm Lionel Wininger. I'm a clinical psychologist at the University of Minnesota. I wear a few different hats, and maybe when I'm presenting, I'll talk a little bit more about them. But I've worked with patients with early psychosis for many years, first with On Track New York, which is similar to the Navigate program on the East Coast. And now I work with the Strengths and Navigate team, a mix of clinical work and some research and program support. I will send it to Tricia.
Hi, good morning. My name is Tricia. I am an IRT clinician at the Navigate program in Grand Rapids, Michigan. I'm happy to be here, and I will popcorn to Vic.
There we go. Hi, I'm Vic. I'm the peer specialist on the HOPE team, and I will popcorn to Anne.
Hi, everyone. I work at the St. Louis Park Clinic on the Navigate team, and I do IRT and I do family work as well. So now I need to figure out who hasn't gone. Claire, have you gone?
Not yet. No, thanks, Iana. I'm Claire Moser. I'm a supportive employment and education specialist with the HOPE program at Hennepin Healthcare. Great to see everybody. Let me see. I think everybody is gone.
Nope. Mauricia?
Melissa. Oh, yep.
Hi, I think my audio is working now. Hi, I'm Melissa Rosewell. I'm the social work care coordinator and do some therapy in the step down program. I don't know who hasn't gone because I couldn't hear. So
Mauricia?
I can go. I'm Marissa. I'm at the St. Louis Park Navigate doing IRT. This is my final year as an MSW student at St. Kate's. So graduate in a couple months. Yay. All right. Who else needs to go?
Kirsa? Yep.
Yeah, I'm Saoirse. I'm one of our 2 IRTs at the Hennepin Healthcare HOPE program.
And I believe it's Kitra.
Hey everybody, my name is Kitra. I am a mental health program consultant at DHS. And I might be the last one.
Yep, you're it. That's good. All right, we will turn it over to Lionel.
With much fanfare.
Thank you. Yeah, appreciate it. Hi, Piper. And nice to see new faces. And I know many of you. So some of this will be and a kind of old hat. You've heard me already go on my rants about psychotherapy. Let me share my slides and get started here. Let's see. And sometimes this works and sometimes it doesn't, but I'm going to try to do it in presenter view. So can people see the slides, or are they seeing my speaker notes? What are they seeing?
Just the slides.
We can see the
You're
slides.
good.
Oh my God, it actually
worked.
Worked. That's amazing.
That's actually maybe the most impressive. So if you could just teach us how you did that.
Well, I'm just going to sign off and end on a high note here.
Okay, sounds good.
Technology actually worked. So this is good to actually have my slides, but for people who have heard me present in the past year or so, they know that I made a New Year's resolution to try and limit my slides to 5. And for a didactic, that can be a little bit difficult, but I think people are zoomed out and PowerPointed out, and complicating that, I tend to ramble a lot, as many of my colleagues know. So even with 5 slides, I might not get through all of them. And for today, I have 10 slides, but I gave myself a little bit of room for, I don't know, flexibility there, because some of the slides don't even have words on them. So you can already see I've gone back on my resolution. Going to be talking about CBT plus for psychosis. And knowing many of you, I already know that some of you are experienced clinicians, having done psychotherapy for many, many years. Some of you having done psychotherapy with patients for early psychosis for many years. So some of this will be a review, but hopefully there are some people for whom this is new material. I'll give my usual caveats and disclosures. I will then just kind of jump right into the therapies that I'm going to be talking about today. And I'll try to leave room for questions and discussions. Carissa, should I aim to end at 8:45? Is that?
Yep, that's the goal.
Okay, I will. The other nice thing about this presenter view is it has a clock on it staring me down, so I know exactly just how far behind I am. So why don't I start, I guess, again, just introducing myself. As I mentioned, I'm a clinical psychologist. I moved to Minneapolis about 1.5 years ago, and have been working with the Strengths and Navigate teams. I used to work for On Track New York, which Piper or someone else has probably mentioned at some point is a similar coordinated specialty care program, mostly based in New York. There are about 25 teams throughout New York. So while I was in grad school, I thought I was going to study personality disorders and become a forensic psychologist. So I did a clinical placement on the Bellevue Forensic Inpatient Unit, ended up working with a young man with first break psychosis, as they called it back then. And that changed the trajectory of my entire career. I really found a home with On Track New York and the kind of research and clinical work that they were doing, and kind of haven't looked back. The other part of my career that I tell people about is that I was, New York has a few different psychology graduate school programs, and many of them have a psychoanalytic or psychodynamic tilt to them, which is not the case throughout the entire country. It seems to be kind of in pockets, but that also influenced, I think, a lot of my clinical work with patients with psychosis. So I'll talk about, you can see that the last kind of therapy I mentioned is integrative, using both CBT and psychodynamic principles. So in my experience talking about this, that's where there's sometimes some new material for people who have been in this field for many years. Let's see. I give some caveats and assumptions. My assumptions are that, again, that I don't have to kind of go over all of the symptoms of psychosis, and that, for people who've been on these echo calls, you've heard a lot about what the kind of general or common experiences of psychosis are, and you recognize that there's a lot of heterogeneity, that people, with that diagnosis of a schizophrenia spectrum illness or another disorder where psychosis is present, even when the diagnosis is exactly the same and the thumbnail sketch is exactly the same, you could have 2 completely different experiences, 2 different family experiences, 2 different opinions from providers looking at the same patients. So I always mention that we don't fully understand psychosis. We don't have a litmus test for it. Many of the kind of thresholds we use are somewhat arbitrary, right? We say, you know, we talk about conviction, or we talk about the intensity and frequency of symptoms, but we don't just have like a universal gold standard definition that everyone agrees to. The same is true for psychotherapy research. So, you know, we're talking, I'm going to talk about, you know, ostensibly comparing different psychotherapies and how they work, but I have given up on like the war of psychotherapies. I don't think like one is best, and I'll talk about that a little bit later. But just to, you know, this is kind of a plea for humility when we talk about psychosis and when we talk about psychotherapy, that no one treatment will work for everyone. If anyone tells you that they've found a treatment that works for 100% of any psychiatric illness, depression, anxiety, borderline personality disorder, I'd be skeptical. I have no financial disclosures. I have no skin in the game, so to speak, with the exception, you know, that I tell people I've kind of drank the Kool-Aid when it comes to coordinated specialty care. I think the best treatment for people is a combination of psychotherapy, medication, family support, job and school support. So that's my bias that I tell people up front. And the other thing I'll mention is that I'm only going to talk about a few of the psychotherapies today. And you'll see on this next slide, any therapy that you've heard of out there that you can name, someone has tried to, and in some cases successfully, apply that to working with psychosis. So, you know, some of these books are familiar to people. Maybe the Susan Gingrich Social Skills for Schizophrenia book, that was part of my early education. But we have DBT for psychosis. We have ACT and mindfulness for psychosis, psychoanalysis and psychosis, CBT. So just to kind of keep in mind that there are tons and tons of people interested in applying different psychotherapies to working with patients with psychosis. You know, when we talk about early psychosis or first break psychosis, there's less, I would say, and that's something that's probably changing in the past 10, 20 years. You know, there's become such a kind of heightened interest in working with early psychosis and this kind of preventative interest with CHR and prodromal psychosis that we're going to start to see manuals, and we're going to start to see randomized control trials probably for specific therapies with psychosis. I'm not going to go into a lot of the research today, since this is more of a clinical talk, but just food for thought. So let's jump into CBT for psychosis. This one, I don't know how familiar people are with CBT for psychosis, but most of you are probably familiar with CBT. It relies on a model of thoughts, feelings, and behaviors. This is the original kind of cognitive triangle you all know about. And then more recently, of course, recently, probably 30, 40 years ago, they added the notion of situation and context, right? So that people are not kind of experiencing the psychological world in a vacuum, but that there are pre-existing factors and situational factors that, of course, affect our mental processes. CBT, if you look back, you can find Beck describing CBT work with patients with chronic schizophrenia as early as the 50s. And, you know, Beck, as most of you know, kind of was came from the psychoanalytic world, and really shifted the focus towards conscious processes rather than unconscious conflicts. But really, saw the cognitive triangle, this kind of especially thoughts, as being like the way not just to interpret psychosis and the way to kind of understand things, but he also saw it as the target for intervention. So if we can kind of think about psychosis in cognitive terms, the way it's most often described is that a hallucination is a misinterpreted kind of signal from the body. It's misinterpreted context within the model. A delusion can be thought of as an extreme inaccuracy, an extreme disordered thought, or an extreme disordered belief. So the goal of treatment, if you're thinking about CBT for psychosis, is similar to what the goal is for CBT for other symptoms. It's to challenge inaccurate thoughts. It's to challenge unhelpful thinking styles, and to, at an extreme level, improve reality testing, right? So this is something, again, people who have done CBT before sometimes find a kind of natural extension of their work when they think about psychosis. You can use subjective units of distress, right? The SUDS scale, and say, on a scale from 1 to 10, how upset were you when you were experiencing, when you were hearing voices, when you were having this thought that people were surveilling you or out to get you. You can also find, that people measuring using subjective units of conviction, right? And if you've ever asked a patient on a scale from 1 to 10, or from a scale from 0 to 100, how sure are you that your family is trying to poison you? How sure are you that there's voices of someone who's trying to hurt you? That's a subjective unit of distress, and that's again something that can be helpful not just for research purposes and kind of measuring the patient's level of symptoms, but that's also in some cases giving the patients the language, and not just language, but the kind of idea that what they're experiencing is something that can fluctuate over time. That's something, if you've worked with people with psychosis, you probably have seen that or heard that from week to week, the psychotic experience changes. It's not something that's just, for patients is always just static. And so that this again is, helpful in giving patients the kind of insight to recognize that, eventually they may see patterns in their experience. They may see patterns in the symptoms. They may see how they respond to treatment, whether that's the therapy itself or to other factors in their life, things like medications, things like positive kind of psychosocial events, graduating, or being in a relationship, things like that. I'm going to pause while I go to the next slide. So just to, let's see if, well, now I've lost my other screen. Let's see if I can, oh, here it is. So this is an example of a slide. This is taken from the Myrick CBT manual, CBT for psychosis manual, developed in large part by Yulia Landa, who's, I think she's still in New York, but this is who I was trained in CBT for psychosis. And when you do the CBT for psychosis training, at one point they had a whole host of grant funds, not just from the VA, but from hospitals and private institutions. And my recollection of this training, that this is probably, now it's 10 years ago that I did this training. They put 4 cameras at different angles so that you can watch yourself, and they have actors portraying people with psychosis. And while you're training, they kind of show you how you're reacting to what patients are saying. So if you ever kind of want to be in a super anxiety provoking training, I recommend you do the CBT for psychosis training. This diagram, as you can see, again, kind of goes along with the thoughts, feelings, and behaviors model, but adds in just the experience of voices. And you can see voices kind of like don't fit in perhaps like neatly into the model, but are kind of like centered here because for many patients, these again, that we can think of as kind of affecting how people behave, affecting how people think, but also that there are cycles here. You can see there are arrows in both directions, and of course, we know this, that patients might report having anxiety, might report having depression, and that the actual symptom that they're kind of talking about or thinking about is not necessarily what you're targeting or what you're thinking about. I'll pause for a second and open it up for questions, but maybe what I'll ask is, when you see the beliefs down here in the orange box, these are some of the beliefs that, theoretically a patient has about their voices. So he says they're a higher power, they must be accurate. They have another belief that says, I can't hold a conversation because of them. And then you have, and the last one says, this will never stop and I'll have to go to the hospital. So if you were thinking about working with this patient from a CBT for psychosis perspective, what do you suppose you would be thinking about here? Or what do you suppose you would be targeting here? If you had to pick one, you can just pick one, but anyone?
If I had to pick one, Lionel, I'd start with I cannot hold a conversation because of them.
Why would you start there, Piper?
Well, for me, it's a really nice target that you can target with about like how often does this hold up, right? Is it only in certain times? Is it certain ways? Are there ways to measure the ability to hold a conversation, which seem much more reasonable as a place to start to show some flexibility?
Yeah. So that's exactly right. That's where I would start as well. And what I tell people about CBT for psychosis is to start with the belief that you would challenge with any other patient, right? Because the idea that people, I can't hold a conversation because I'm too distracted, regardless of whether you're distracted by voices or by your own kind of self-talk, your negative self-talk or social anxiety, that one feels what we, kind of like ripe for CBT, right? So that's where we would start. And I would discourage you from starting with something like the voices are a higher power and that they must be accurate. In part, as Piper said, because that's harder to disprove. We don't necessarily have a way of kind of challenging that. But also because that's something that potentially is directly related to the experience of hearing voices. And as I'll get into in the later discussion, that might be something that's actually more meaningful to the patient's sense of identity. That might be something that you actually don't know how much you want to challenge, right? And this is something that's come from a lot from the peer world, and also if you're familiar with the Hearing Voices Network. There's nothing inherently pathological about someone who says, I hear a voice. And we know that because there are people who have positive experiences with hearing voices. Sometimes there are patients, but also other people who describe religious experiences and cultural experiences this way. So challenging the notion that, a patient's experience is coming from God or coming from a kind of higher power might be hard to do, but it also might not be kind of in your patient's best interest and in the therapy's best interest. Does that make sense to people? If people have questions or thoughts about that? Okay. Again, I'll leave time at the end for more discussions about this. For the sake of time, I'll try to move through the slides. So let's talk about integrative psychotherapy for psychosis. And again, when I say integrative, now I'm talking about integrating CBT principles and psychodynamic principles. There's a wonderful psychiatrist in New York named Michael Garrett, who wrote a book. Actually, I'll just show the cover of the book. It's called Psychotherapy for Psychosis, Integrating CBT and Psychodynamic Treatment. I'll say Michael Garrett's real claim to fame is that he's married to one of my idols, Nancy McWilliams, who's very big in the psychodynamic world. And he originally, is trained as an inpatient psychiatrist and mostly involved with, training residents on how to work in inpatient settings and emergency settings. But then later in his career kind of took more of an interest in the outpatient work of seeing people with psychosis who had kind of gotten over the initial crisis or episodes of hospitalization, and now we're kind of coming back to therapy either in a what we would call like a later stage of recovery, or kind of starting to re-experience symptoms again. But what Michael Garrett kind of saw, and again, he's someone who, also trained in the cognitive world and in the psychodynamic world, as is kind of common in New York. But while these kind of schools of therapy were warring and battling each other over who had the best way to kind of treat depression and anxiety, he saw strengths in both of the approaches for working with people with psychosis. And the way I kind of summarize this for talking to people who are considering integrating psychodynamic principles into their work is to think of how strong, how kind of like what the real power of CBT is. And that's in challenging the literal falsity of symptoms. Right. And I'm not just talking about psychosis, but, for depression and anxiety, think about all of the work that you do gathering evidence and challenging patients' experience. It doesn't mean you're challenging them, other parts of their life. You might be validating and supportive in many, many ways. But with regards to their experience of social anxiety, with regards to their experience of, negative self-talk in the context of depression, you're trying to build a case that these are inaccurate and untrue symptoms, right? Like, how can we give you positive self-talk to defeat that, the negative self-talk? And if we think about that for psychosis, when we talked about the, subjective units of conviction and distress and the inaccuracies of psychotic experiences, there's a real kind of direction you take, which is disproving symptoms. And there is evidence that that's helpful for people. Again, especially in the early stages of psychosis, when there is potentially confusion, there is mixed insight. Indirectly or directly, you're helping the patient work towards kind of like a more coherent reality, something closer to again, what we would call just good reality testing. So that's its strength. And if you think about psychodynamic treatment, and again, not just for psychosis, but for other symptoms, what you're often searching for is the figurative truth and the meaning and purpose behind symptoms. And this is where you get into the you can think about the context of psychosis, not just what the symptom is, but what the patient is saying, what the patient is believing. So that's when I talk about the figurative truth. An example we can give is a patient who has auditory hallucinations of a derogatory, demeaning voice. I'll give the literal falsity of that. I'll give that answer is that those voices we are presuming do not actually exist. They are not being produced by someone in the patient's life. And this is an internal experience, and that's what the literal falsity is. So I'll ask the group, can you come up with an idea of what a figurative truth would be for those voices? Let's say the voices are saying, you're worthless and you deserve to die. Anyone? There's no literal truth to those statements, right? That the patient deserves to die or the patient is worthless. What's the figurative, potentially theoretical truth? Where did that come from?
Like perhaps some sort of underlying narrative that they have about themselves, that they are, not good enough or don't have value.
Or maybe they were told that by somebody else.
Right.
Yeah. I had a patient who, after about 2 years of treatment, was in and out of hospitals, and this was his experience of hearing derogatory, demeaning voices, was in a better place. And after 2 years, started to talk to me about his relationship with his father, who he was estranged from, and began talking about what were the messages he received as a kid. And he, as he was going through them, said, among other kinds of abuse, there was physical abuse, but there was a verbal abuse that, when he didn't get a good grade, he was told he was worthless and he wouldn't amount to anything. He then also kind of started connecting the dots to, his video game habit, and when he didn't do well, literally hearing people in his ear telling him to kill himself, that he was worthless. And so as he was talking about this, he recognized that some of the things that he had heard were also the experiences of auditory hallucinations, that when he was psychotic, oftentimes the voices would say literally the exact same thing his father said, or literally the exact same thing that someone in his video game had said to him. And this was a revelation for him. It won't be a revelation for all patients, and it won't always be the experience that people who hear derogatory voices were abused or have that. But to Carissa's point, sometimes it comes from an internal narrative and an internal fear that the patient actually is worthless, or that the patient does deserve to die. So this is, in contrast to, when we see someone with chronic florid schizophrenia and are trying to interpret, word salad, I would argue, one, that there's content in there to be analyzed. There is some meaningful content in there. But for patients who hear voices with coherent messages, very oftentimes this is not just noise. This is not just a crossed signal or a misinterpretation of some random happening in their life. These are coming from meaningful psychological places. The other example people have heard me talk about before is that for many patients, again, I'm speaking in general terms, but not for all patients, but for many patients, the psychotic thought, the belief, the experience takes hold of or takes on the content that's very important to the patient. That can have to do with trauma, as it does in my example. It can take on or kind of take hold of identity, the patient's sexual orientation, even their racial identity. It takes hold of things that are important for people, religious experiences. Oftentimes the experience of psychosis has religious elements to it. So this, again, to me is a reason for integrating psychodynamic work into the CBT work, because you can simultaneously, and this is maybe there's a dialectic to be found in here, you can simultaneously think about the literal falsity of symptoms and the figurative truth of them. So you can work towards, especially when there are beliefs that are easily challenged, like I'll never be able to hold a conversation with someone, or I'll have to live in a hospital for the rest of my life. You can challenge those beliefs and think to yourself, and sometimes ask the patient to think for themselves, where is that thought coming from? It's not true, but how did I get there? So it's a balance of challenging and validating, which, again, I think most people do in their work, regardless of what kind of therapy they're doing. You're doing some amount of challenging and validating, but to use that for the work you're doing in psychosis, I think is important too. One of the strengths of this, I think, it can be done in phases. And as I put here, my last bullet point is that my personal experience is that this is integrating psychodynamic principles into work is less successful, or kind of feels less appropriate at the beginning stages of treatment. Oftentimes because you're dealing with a crisis, or you're dealing with some of the kind of practical consequences of a hospitalization, of a new diagnosis, of confusion around the experience. So you're oftentimes kind of like weathering the storm and really focusing on reducing symptoms rather than understanding where they came from. And again, some people have told me that, people wanted to jump right into this kind of work, into kind of understanding what the symptoms mean. But in my experience, that's oftentimes comes, and one, it doesn't come for everyone that they say, I want to understand my symptoms. But when it does, that's often been later in recovery. Kind of the other principle people have heard me kind of talk about is striking while the iron is cold, right? As opposed to striking while the iron is hot, and hot meaning there's kind of the symptoms are at a high acuity level and there's a real kind of crisis of identity. That can actually be a challenging time to think about the meaning behind the symptoms. All right, my last slide is about, I end on what I think is the best psychotherapy for psychosis, which, as I said, my bias is that coordinated specialty care, I think, provides the best psychotherapeutic experience for patients. So many of you know about the Navigate model and individualized resiliency training. Many of you are IRT clinicians. OnTrack has something similar, less manualized in the way of core sessions for their primary clinicians. And I would defer to Piper on this, and when I say studied, I mean kind of like anecdotally. I don't think there's been like a large scale study of IRTs, but generally when we look at what therapists are doing in the real world, it usually falls into a category of supportive plus CBT, right? So we emphasize psychoeducation, relapse prevention, motivational enhancement, motivational interviewing, and CBT skills. So there might be some kind of low consistency, even within your teams. You may think, well, this person who's also an IRT is doing work that's slightly different from mine. And it's probably true that across the country, people are doing different forms of psychotherapy with patients in coordinated specialty care, but that's actually a strength. I don't think people should think of that as a weakness. Heterogeneity is only bad from a research perspective, right? Like heterogeneity is kind of something we're trying to reduce when we do a randomized control trial, or when we kind of look to think about fidelity of a model. So there's something important there for consistency and delivering a similar model of treatment for people. But it's actually important to recognize, again, the heterogeneity of the patients we're working with, patients who present with psychosis, even when they have the same diagnosis and are the same age. That we have patients who come to us with depression. We have patients who come to us with psychosis and anxiety, psychosis and trauma, and BPD and mood disorders, and any other psychiatric illness that you can think of. You probably will at some point see just working with patients who have psychosis. So really there's quite a strength in being flexible in your approach. For CSC models, something I think that's really important is taking a phase-specific approach, individualizing your care and focusing on recovery. But what recovery means for someone who's just had their first hospitalization is different for someone who has had their 5th hospitalization and has been in treatment for 2 years. So you probably all kind of know that on some level. But I think that it's important to have multiple tools in your tool belt, in part just because of the heterogeneity and fluctuating nature of psychosis, right? Like what works, you've probably had the experience that what works 1 week with one patient doesn't work the next week with the patient. So this is hard work. I also tell people that psychotherapy is challenging work, and psychotherapy with psychosis is some of the most challenging work you'll do. I'll end there. Just thinking, okay, I went 2 minutes over, but I'll open it up for questions and discussion now.
Thank you, Lionel. That was a very thoughtful presentation. I'm curious if folks have questions for Lionel.
Lionel, I just have to thank you for the style of your presentation, not being a clinical therapist. You just really unpacked it in a very cohesive, understandable way, I think, for all the different roles on the team. So thank you. I really appreciated that. It was very informative.
Thanks, Nancy.
A question about when we're using CBT to kind of challenge the beliefs, and maybe they get to a point where they don't have conviction, they know that their delusions or symptoms aren't real, but they're still distressed by them. Is that a helpful time to shift to psychodynamic and kind of get to the deeper kind of underpinnings of that? Or how do you typically approach that when they know it's not real, they're really good at reality testing, but they're still distressed by, for instance, hallucinations?
Potentially. I mean, and I think it's helpful to, let the patient guide you in that way when they say they're distressed by the experience. Like, I know it's not real. I know this is part of my illness. One, that's a great stage of insight for someone to be there, but to kind of say, well, why is that distressing for you? And before you jump into kind of thinking about the meaning and the purpose behind it, if oftentimes what they jump to is something that has to do with a myth of severe mental illness, like I will have this forever, and I will not be able to work, or I'm permanently disabled, and so sometimes there's a negative stigma attached to the diagnosis. And maybe if you've had a presentation in the Echo Clinic around suicidality, this has come up, that there is sometimes a heightened depression or a suicidal response to that insight. So this is a really kind of tricky, careful time in therapy when a patient has come to a realization, an insight that they have a mental illness or that they have psychosis, and they're starting to accept it. That unfortunately can also be a time when there's a negative stigma attached to it, and they're worried about their future. So I would start with listening for that. But I think, yeah, that's a time, again, once you've kind of, you don't always get there so great when it happens, but once you've kind of reduced the conviction around the experiences, the delusions and the hallucinations, it's a great time. I mean, that's when you start seeing people kind of take interest in the meaning of their symptoms or think about their relationships, things like that.
Thank you.
Sure.
I have a question, and it's kind of like the phase before that. When I have kind of two-part question, but when you're working with someone and you're trying to weigh the evidence, and the evidence to them is also based or not based in reality, like, what is your evidence that all these people, want to hurt you? And he says, well, they tell me they want to hurt me, and they are looking at me funny. I'm just kind of having a hard time, like, flipping it, so any thoughts on that? And then also in the kind of triangle chart for CBT. Yeah, thanks. I'm wondering, is the voices portion of this, can that be replaced with delusions or paranoia or physical sensations other than voices, and kind of go with that? Because for folks maybe who don't have such prominent auditory hallucinations, just wondering if you've done that.
Yeah, and I don't necessarily encourage people to think this way, but the way psychoanalysts think about voices is that those are just your thoughts. Like that's just your unconscious speaking to you. Again, like that's not necessarily the way I think about it with patients, but it's sometimes helpful for thinking about the meaning. When a voice says, you'll never get a girlfriend, or the men behind you are going to hit you, things like that. That's what they would call a primary process. So that can also be thought of as like, a delusion, again, is the oftentimes the more harmful part of the psychotic experience, right? If the experience of hearing voices does not have a negative message and doesn't bring on distress or distraction, then what are we treating exactly? We're just treating a different experience. So the first part of your question, I thought this often comes up, is like, well, I have patients who are the thought process and justification, or kind of all of these experiences have a delusional or psychotic component to it. And I will say that for patients with conviction around their delusions, sometimes even reducing the conviction there, reducing the kind of delusion in one area, you see it pop up in another. And it can be challenging to try and build a case, or try and kind of like work to find evidence for things that we would call, reality-based. So at some point, yeah, I have patients for whom I don't touch the delusion. I'm working with a patient right now who has a delusion about something that happened two years ago. And realistically, there will never be any way for him or for me to kind of gather evidence about it and disprove his beliefs around what happened. So if that's the case, I don't make like advice or kind of guidelines for like catching all, but I think it's worth thinking about whether it's helping to kind of build evidence against the delusion. The IRT manual, I would say, actually is good about this again, and thinking about those kind of lesser delusional thoughts, kind of working to challenge those as a kind of gateway towards perhaps challenging the delusion itself. Now I'm rambling, so Melissa,
No, this is great.
At all?
Yes, absolutely. And I'm newer to doing this, so it's really
and I would say, Lionel, you said it best. I mean, I think that we've been doing this long enough to know that a cognitive approach is not going to work for everybody, and that's what you're talking about, Melissa. And I think, it's just, it is what it is. This is where this person is, and right now there's no movement in that area. So banging your head up against a wall where all of the evidence is fits in that same framework, that same perspective, is not going to change anything. So that's when you back up, and in a CBT framework, we would say move into the behavioral based strategies of, as a result of believing that way, what are some consequences? What is with the result of that? So that can we move into some behavioral based strategies to help you cope with the consequences. But I think there are other approaches too. This is just the tried and true framework that we have, and that's pretty readily available. But I think it's just not going to be helpful for this person, because that's the level of conviction they have across the board in that perspective.
Gotcha. Yeah, it makes sense. Thanks.
I don't argue with patients about their delusions, and I don't encourage anyone else to do that. I don't think, Melissa, you would do that either. I'll argue with them about other things if that's part of our relationship. Their romantic partner, their politics, their whatever it may be. But this is something we know that there are some patients. Again, for one of my patient who has like the most conviction around his delusion, there are no voices, there are no negative symptoms. That may be like 50 years from now, we may call that something different. Patient who just has that really kind of hardened delusion around something. And we know, yeah, it pops up other places if you reduce it in one area.
I want to be sensitive to time, so I want to give Claire plenty of time for her case presentation. But thank you, Lionel. This was fantastic, and I love that you made us think really differently. So I appreciate you today. You are more than welcome to stay. We would love to have you stay to listen to Claire, but we certainly understand if you have other things that you need to move on to. So I just want to say thank you.
Sure, no, I planned on staying, so thanks, and thanks for having me.